Good morning. Today's class is about open bite and its management. The malocclusion that we see, whether it's skeletal or dental, we can see in three different planes of space. It can be seen in mid-sagittal plane, vertical or horizontal plane. So open bite is a malocclusion that we see in the vertical plane. It is characterized by lack of vertical overlap between the maxillary and mandibular dentition. So before we try to treat any malocclusion, we need to understand its etiology and we need to eliminate it in order to get a stable treatment. So by definition, an open bite is a descriptive term for a condition where the space exists between the occlusal or incisal surfaces of maxillary and mandibular teeth in buccal or the anterior segments when the mandible is brought into habitual or centric occlusion. So we can broadly classify the crossbites into anterior crossbite and posterior crossbite depending on the location of the crossbite. So this is how the anterior crossbite looks, where there is a gap between the upper and lower anterior teeth. This is a posterior crossbite. So this is seen in the premolar molar area where the upper teeth do not overlap the lower dentition. Then based on whether it is a skeletal or a dental kind of a malocclusion, open bite can be a skeletal open bite or a dental open bite. So in a skeletal open bite, predominantly the problem is with the upper and lower jaws, whereas in the dental crossbite it is because of the proclination of the teeth because of any habit. Anterior open bite, so basically it is a condition where there is no overlap between the upper and lower anterior teeth. So what causes this anterior open bite? So it could be a hereditary or a non-hereditary condition and it can be a multifactorial issue. So habits such as thumb sucking, tongue thrusting, sometimes even mouth breathing associated with any nasal obstruction can result in this kind of a malocclusion. The intensity of the habit will also decide the severity of the condition that we see. Then presence of a large tongue and abnormal skeletal growth pattern can also contribute to this malocclusion. So what are the different features of anterior open bite? So if we see a skeletal anterior open bite, we already told that it is because of the abnormal jaw growth. So here we see increased lower anterior facial height, increased overall anterior facial height, and posterior facial height is reduced. There is a steep mandibular plane angle. So that means the mandible is rotated clockwise and the body of the ramus and the body and the ramus of the mandible are small. Also, it can be associated with a short upper lip, long narrow face. The jaw bases, that is maxillary and mandibular jaw bases, are moving away from each other, that is they are divergent. There is a steep anterior cranial base, incompetent lips and marked antigonial notch. So in this diagram if you see, it is a X-ray of an open bite patient where we can see short ramus with a prominent antigonial notch. We can see that the maxillary occlusal plane is diverging upwards and the mandibular plane is diverging down. There is a overall increase in the anterior facial height. Coming to the intraoral features, it can be associated with mild crowding. The incisors are usually upright in a skeletal anterior open bite. There could be gingival hypertrophy because of incompetent lips. The maxillary occlusal and palatal planes that tilt upwards and the mandibular occlusal plane is canted down. Coming to the dental anterior open bite, so here the skeletal bases, that is the maxilla and mandible, properly oriented, but the teeth they do not overlap each other because of proclination or any habit. So usually it is associated with proclined upper, sometimes even proclined lower teeth, narrow maxillary arch, sometimes even spacing can be seen. No particular extraoral features are seen in dental anterior open bite. So here we can see there is a proclination, the upper anterior teeth are proclined and the tongue seems to be coming into the space between the upper and lower teeth. So here there may be an associated tongue thrusting habit. So what is the treatment? For any management of any malocclusion, we need to first eliminate the cause. So if the open bite is because of habits such as tongue thrusting, thumb sucking or mouth breathing, we need to first eliminate that habit with the use of habit breaking appliances. So this habit breaking appliances can be either a fixed appliance or a removable appliance. So in the first picture we can see a removable kind of a tongue clip, and the bottom picture shows a fixed kind of a tongue clip. So removable tongue clip, disadvantage is that the patient can remove it, so he'll not be very compliant with the treatment, whereas for a fixed tongue clip, because it's fixed and they cannot remove, it is more beneficial. Tongue thrust, as we already saw, habit breaking appliance is a tongue clip. For digit sucking, we can first motivate the patient to stop the habit. In case it is not happening, we can remind the patient with the help of certain medicaments which are bitter, acrylic digit caps, or again tongue clip. In case of mouth breathing, usually the etiology is associated adenoids or tonsils, nasal polyps, deviated nasal septum. So anything associated with nasal obstruction has to be first cleared with the help of ENT consultations. Once this is done, we can suggest certain breathing exercises and mouth shield to overcome this mouth breathing habit. So once the cause is removed, especially in the growing children, automatically the open bite tends to regress spontaneously. So in the growing patient, if the open bite is very severe, such as in case of a skeletal malocclusion, we can, because the child is growing, we can also give myofunctional type of appliances. So examples are Frankel 4 or modified kind of a activator. So these myofunctional appliances, they basically have certain occlusal bite blocks present in between the posterior teeth. So these posterior bite blocks, they help in intruding the posterior teeth. So once the posterior teeth are intruded, the wedging effect is removed and the open bite gets corrected. Also we can give a chin cup, which is the chin cup is placed near the chin. So this gives a intrusive kind of force in the anterior region, again helping with the correction of anterior open bite. So here we can see the child is wearing a chin cup appliance, which has a upward directed force. Also in the second picture we can see that the bite blocks of the activator appliance, they are placed in between the upper and lower posterior teeth. So these give a intrusive force on the posterior teeth. Then that was growth modification. Coming to proper orthodontic treatment with fixed appliances. So this is usually undertaken when it is a mild to moderate kind of a anterior open bite and where the growth is almost over. So in this case we can put braces and close the anterior open bite with the help of elastics with medium to heavy force. So these elastics, they look something like this. Okay, so we have elastics running between the upper and lower anterior teeth. So this it pulls the upper and lower teeth together, helping in closure of the open bite. Then open bite can be closed either with the extrusion of anterior teeth or with the intrusion of the posterior teeth. So in case we consider that anterior intrusion is not favorable for the facial aesthetics, we have to intrude the posterior teeth. So this can be done with the help of temporary anchorage devices and bite planes. Then in severe skeletal anterior open bites, where the patient is an adult patient and there is no growth, so in that case, orthodontic treatment or growth modification cannot be done. So in these kind of cases, the patient is put for orthognathic surgeries. So usually Leefort-1 kind of surgery is done with maxillary posterior impaction in order to correct the open bite. So if we can see here in the first picture, after the osteotomy cut, posteriorly more wedge of bone is removed and it is superiorly repositioned in order to close the open bite. Post-surgery, muscle training has to be done. Coming to the posterior open bite, it is not that common as we see the anterior open bite. So this is a condition where there is no overlap between the posterior teeth. As we see in the picture, there is gap between the premolar and molar area. So again, etiology is when the eruption of the teeth is blocked by any mechanical interference. It could be because of ankylosis of the teeth or because of any supernumerary teeth blocking the eruption of the permanent tooth, or because of any non-resorbing deciduous tooth which is retained in the jaw. Also, it could be because of primary failure of the eruptive mechanism of the tooth without any interference from other structures. And lateral tongue thrusting can also be a factor. So treatment, again elimination of the cause. Genetic factors or eruption, tooth eruption cannot be controlled by orthodontist, but in case there is a lateral tongue thrusting habit, that can be corrected with the help of lateral tongue crib or tongue spur. So it looks like this on the posterior region. So this is the premolar and molar area where we have the wire components blocking the tongue from moving into the open bite space. So once this space is blocked, the posteriors are free to erupt and the open bite closes. Second, in case the posterior open bite is large enough, we can again give elastics along with fixed appliances. So this is how the elastics look. So this is a fixed appliance with elastics passing over the premolars, which again pull the teeth together, resulting in the closure of the open bite. So in case of submerged teeth or there is infra-eruption of any teeth, for that also we can use fixed mechanotherapy. Sometimes either the permanent tooth or the deciduous tooth is ankylosed. So we cannot do anything about the ankylosed tooth because there is no PDL there to move the tooth. So in such case we can go for prosthetic options. That is, we can give the crowns or processes over these ankylosed teeth to establish the proper occlusal plane and to close the open bite. So to conclude, first, for any treatment, we have to eliminate the etiology and then plan the correction, followed by retention of the corrected malocclusion. Thank you.